Alright, the topic I'm going to be discussing today is angina pectoralis, otherwise known as just simply angina. Angina is a condition caused by reduced blood flow to the heart. It's not a disease in itself, but a symptom of other conditions. It can be a recurring condition or it can be an acute condition. And there are 10.2 million cases in the U.S., with 500,000 new cases every year. It's slightly more common in men than women, but it's not a huge difference. The symptoms of angina are chest pain, and this chest pain can also be associated with pain in the arm, jaw, shoulders, neck, or back. This picture shows the areas in red are where you'll have pain. So you can see the chest going down the arms, usually the left arm, the upper back, and into the jaw. It can also present with fatigue, nausea, shortness of breath, sweating, dizziness. And it's classified into one of three categories. The first one is stable. This one's caused with exertion, such as exercise, climbing upstairs, things like that. It's predictable. People that this is a recurring condition for them, so they know if they exert themselves they're going to get chest pain to some extent. It also is short duration and it resolves with rest. So as you exert yourself, you'll start to feel that chest pain, but once you start to rest, the pain will subside. The next type of angina is unstable angina. This one occurs at rest and it can be unexpected. It's not as predictable as the stable one, and it's also a more severe pain. It can last up to 30 minutes, which is significantly longer than the stable angina. And this is the one that's considered a medical emergency. If somebody is experiencing this, they need immediate medical attention. They need to go to a hospital immediately. And the last type is variant angina, also known as Prinzmetal angina. This one is much more uncommon. It's only seen in about 2% of the cases. The symptoms are similar to unstable angina, but the difference is how it's caused. This one is caused by spasm of the coronary artery rather than a blockage. And like I said, the causes are reduced blood flow to the heart. Right here you can see a normal artery, and right here is the one that has a plaque blockage. So the heart needs to pump harder to get through that narrower space, which causes the pain. And with the stable angina, it's caused by an increased demand for blood brought on by things such as exercise, stress. And unstable angina differs in the fact that it's usually caused by a rupture of the plaque in the coronary artery. So as you can see the plaque here, a piece of it will rupture and break off, and further down in the artery it will cause a blockage, which causes the angina. Alright, and the risk factors are things such as age, lack of exercise, obesity, stress, tobacco use, diabetes, hypertension, high cholesterol, and high triglycerides. And like you can see, a lot of these risk factors are things that are dependent on the person. Things like age and stress aren't as modifiable, but some of the factors such as lack of exercise, tobacco use, high cholesterol, they can be changed and can improve the health of the person that is experiencing the angina. Alright, so also there are various treatments for it. The first ones, the non-invasive treatments, are primarily exercise. The exercise you want to use is gentle, sustained, low-intensity exercise. A lot of times people that experience angina, the chest pain will come on almost immediately after they start exercising, so they can't really exercise at a very high level. But as long as you're able to sustain it for any significant duration of time, you're going to get some benefits out of it. And the main goals of exercise are to promote collateralization. So the blood vessels in the heart, you want them to kind of grow so they work around the blockages that may exist. Also to lower blood pressure. And there's various medications that you can use to control the angina. The first one's nitroglycerin, which is vasodilator. That's going to widen the artery, allowing blood to pass through it easily. And then there's beta blockers and calcium channel blockers. These are the ones that are going to dampen the effects of adrenaline, and it'll reduce the demand put on the heart. And lastly, there are surgical treatments. The first one's a balloon angioplasty. This one is where they feed a catheter through an artery into the area that's blocked, and they inflate a balloon that's going to widen the blood vessel, allowing more blood to flow through. The next one are stents. This one's similar to the balloon angioplasty, but they do the same thing, and when they inflate it, they leave a stent which holds the space of the artery open. And the last one, there's coronary bypass surgery. This one is where they surgically change where the arteries go to reroute the blood past the blocked area. There can be multiple bypasses, so it could be a double bypass, triple bypass, depending on how many blockages there are and where the blockages are. Okay, so the first study that I looked at was titled Angina with Normal Coronary Arteries, and this was was more of a clinical review that looked at several different papers, and it was looking at many women came in with the complaint of chest pain, but they didn't have any obstruction in the arteries. And women tend to have different causes for chest pain. Men, it's typically just having an obstruction in the arteries. Women, they see Prinzmetal angina more often. It's also due to stress that they might be getting chest pains. It was previously thought to be benign. A lot of times doctors would sort of brush it off as caused by stress or muscular things like that. But looking at all these papers and the outcomes of the patients that did come in complaining of chest pains, down the road they experienced coronary diseases and at almost the same rate as people that were diagnosed with obstructive angina. And the main takeaway from this was that angina, even if it is obstructive, should be treated similar to, or even if it's not obstructive, should be treated similar to obstructive angina. One of the main causes they believe that is causing the non-obstructive angina is due to endothelial dysfunction. And the next paper I looked at was titled Submaximal Exercise Testing After Stabilization of Unstable Angina Pectoralis. So this one looked at 125 patients, and 60 of them they followed up within the next year. So these patients all were hospitalized with unstable angina, and after they were eventually stabilized, they were 3 days post that, they performed an exercise test, and the test they performed was the modified NAUT protocol. This test, they started them out at 2 miles per hour, and they started them at a 0% grade, and they increased the grade 3.5% every 3 minutes. And if the patient reached 18 minutes, they moved the grade up to the speed up to 3 miles per hour, and they moved the grade to 12.5, whereby they started increasing the grade by 2.5% every 3 minutes after that. So termination for the test was determined if the patient reached 70% heart rate, if they experienced further angina, dyspnea, fatigue, dizziness, if their systolic blood pressure dropped greater than 15 millimeters of mercury, or their ST segment on an EKG showed a depression of 2 millimeters or greater. And it was considered a positive test if they experienced angina or ST depression. So the results that they found were that 48% of the tests showed a positive test, and after following up with them 1 year later, they found out that 43% of them had a favorable outcome, while 57% had an unfavorable outcome, meaning that they either returned to the hospital with further complaints of angina, or they had myocardial infarction or something else of that sort. So the big finding was that 87% of the positive tests had an unfavorable outcome, and only 26% of the negative tests had an unfavorable outcome too. So you can see the results charted here. And the main takeaway was that the exercise test was a good predictor of what patients were going to have a negative